Welcome everyone tonight, and you're in for a treat with Dr. Shen and talking about a cutting edge procedure option. First, I want to go over a little bit about why we hold these heart-to-heart community events. So it's part of our mission at the cardiovascular team, putting on these community events. We want to take care of the hearts of our community so that people live happy and healthier lives. So we do several different things in the community in addition to offering the heart-to-hearts. We have the cooking with heart classes, and I know many of you have done the cooking with heart classes with me. Those are classes that are offered free to the community where you become confident in preparing delicious dishes that don't take a lot of time. So you're welcome to sign up. We've got classes coming up in August and September. So that's the link there, and you should have in your packet there, you should have a brochure about it there. So if you're welcome to ask me any questions, so I'd love to talk to you about that. We also have free blood pressures that we did here. Many of you took advantage of that, but I want to point out and say a big thank you to Cheryl, Rosemary, and Linda. You guys, the nurses, can you help me give them any hand in there? Very important to keep on top of your blood pressure. So we also have a newsletter, a Heart Center newsletter we send out once a month on timely topics. If you're not on our newsletter list, see me or see Randy at the check-in desk. You can also reach out to us at that email there on the screen there, or you can call us there. These are different ways that you can get hold of us. So now what I'd like to do is introduce our speaker, Dr. Shen. He's a board-certified cardiac electrophysiologist and cardiologist, specializing in treating patients with heart rhythm disorders. He performs complex cardiac ablations for various heart rhythm diseases, and we're going to hear more about that. He does implants with cardiac devices such as pacemakers, defibrillators, and cardiac resynchronization therapy. He completed his electrophysiology fellowship at Northwestern University in Chicago and clinical cardiology fellowship and postdoctoral research fellowship at Indiana University. Dr. Shen joined cardiovascular medicine in February 2023, and he is the director of cardiovascular research and education. And you will get to see his passion about bringing the latest advanced technology and clinical trials right here in the Quad Cities. He oversees multiple clinical trials involving pharmacological devices and pharmacological therapies for patients with heart rhythm disorders. He's authored dozens of peer-reviewed articles in journals and books and won prestigious awards. Besides work, he enjoys spending time with his wife and his two sons. Please help welcome Dr. Shen.
Thank you, Teresa, for the kind introduction. I see a lot of familiar faces here. Some of them, I think I did an AFib ablation. Some of them probably gonna do some AFib ablation. So I think whether you have AFib or not, this is something I'd like to introduce. Something fairly new, but it's really it's built upon what we already know. So this is not a revolutionized technology or anything, but it's definitely something very exciting, and I'd like to share that with you. So to begin with, who are not my patients? Oh, wow, most people are not my patients. So I overestimate myself. Who have AFib? Oh, okay. So you guys know AFib, right? So I don't have to spend some time to introduce what AFib is, but I do have slides showing what AFib is, but I will quickly move through because who do not know what AFib is? All right, we have one person, maybe two, maybe three, all right. So today, my topic is about something called PFA, pulse field ablation. Pulse field ablation, and for the later talk, I'll just, talk about like PFA. as a new way of doing ablation for people with AFib, okay? So my talk today is gonna be, I hope it will conclude in 30 minutes. I'll save ample time for question and answering, okay, Q&A session. I think a lot of time these are Q&A session actually galvanize some discussion and actually people learn more, okay? So I'll spend maybe very, very minimal time on what is AFib. Why do we care about AFib? What have we been doing so far for AFib, okay? These are part of my slide last year, and I think it is very important to repeat it again. Then we'll go to the real topic for today. What is PFA? What is pulse field ablation, right? And how this is performed here in this hospital, UnityPoint Trinity in Rock Island campus. So what is atrial fibrillation? What is AFib? A lot of you have AFib. What is it? Basically, it's quivering of the top chambers of the heart. Atrium is the top chamber of the heart. It's kind of a receiver of the blood coming from your body. So it's a small pump, if you will. It receives the blood to the bottom chamber with a ventricle that pumps the blood out to the rest of your body. If your top chamber is quivering, it doesn't beat at all. So when you're in AFib, you lose about 25% of your engine of your heart, if you will. It's a small engine, right? So people, they're in AFib, they lose about a quarter of their output of the heart, so to speak. So why do we care about AFib, right? So, you know, some people, they were in AFib for the rest of their life and they seem to do well. Why do we care? We care because, number one, it is very prevalent, right? So I was in the audience and some people asked me about this. People seem to recognize this more. And a lot of people seem to have AFib, you know, around their family, friends, and everything. And I think one of the reasons is people live longer, right? So there are a lot of diseases maybe 30 years ago, 40 years ago, they just didn't happen because, number one, people didn't live this long. Number two, now with the wearable device, you know, Fitbit, Apple Watch, and even the awareness of the medical community, right? The PCP, the primary care doctors, general cardiology, they started to recognize, wow, there's a disease called AFib. Instead of washing it off and see you back in 6 months, let's refer you to a heart doctor who can treat you with this properly. So the incidence go up dramatically. And the estimation, you know, for the next few decades to come, the incidence should keep rising. So we're going to have more and more people with atrial fibrillation. Now, what are the symptoms of AFib? Okay, this is a very important slide. I think a lot of people say, I have AFib, I don't feel it. Yes, you may not feel your heart is racing. Okay, sometimes people feel like their heart is flipping, flopping. People play drums inside their chest. But that is just one of the symptoms. A lot of people, they feel AFib because they feel tired. Okay, shortness of breath, especially when they try to exercise. Dizziness and chest pain. Yes, people can have all these from other medical conditions. These are very non-specific, but people can have AFib presenting in very different ways among, you know, individuals. And there are truly people who don't feel anything for their AFib. They're just fine. They're coming in, you know, for a clinical visit. They're in AFib. They don't know. Next time they come in a normal rhythm, they don't know. So even if you don't have AFib, you don't have symptoms of AFib, you still have increased risk of stroke. Okay, I think this is one of the most important reasons that we treat AFib is because the incidence of stroke goes up significantly. How much? 500%. Okay, if you own a stock, it goes up 500%. You'll be, oh wow, great. But your stroke risk goes up 500%, right? So a lot of people with the proper risk factors, they're on a blood thinner. That's because of this reason. AFib increase the risk of congestive heart failure, right? So when your heart rate is uncontrolled, usually fast, your heart can weaken and your bottom chamber of the heart gets dilated and weakened. That's not good. More recently, we associate AFib with increased risk of dementia. Okay, that was, you know, people think it's a lot of small little clot that goes through make people demented. And then Last but not least, AFib increased risk of death. Okay. This is a Framingham study, Framingham Heart study. They follow thousands of people in the area called Framingham, Massachusetts. They follow them about 10 years of follow-up. You can see that for 55 to 74 years of age, if you have AFib for men, you almost double your mortality. If you're women, you almost triple your mortality. Okay. So is it because of AFib itself? Maybe, maybe not. I don't know. Right. These are observational study, but you can, people with AFib, they tend to be a little bit share risk factors, other risk factors, etc. Maybe that is the reason they increase mortality. But I think we're born in normal rhythm, right? So I think whatever you believe is, the reason why we're born in a normal sinus rhythm is because that is the most efficient way for our heart to pump. Definitely not AFib. If AFib is the most efficient way to pump, we are going to born in AFib, right? So there's no way, the natural way is really the worst way. So I think it makes a lot of sense to restore a normal rhythm if possible. So what have we been doing for atrial fibrillation, for AFib? So this is a slide I used last year. I think it's very important. Yes, today's talk is focusing on ablation. Ablation is just one of the weapons we use for AFib, and it's probably not the most important one, right? It's the sexiest one. Everybody wants to know ablation, everything, but if you go to a doctor and the doctor only tell you about ablation, it's probably not great. You need to look at it a comprehensive way. First of all, you want to control the heart rate during AFib, right? So when your heart rate is really fast, it's not good. You don't feel great. It weakens your heart muscle. You want to take some medication to slow down your heart rate when you're in AFib. Some of those patients are not that liberal. You cannot use rate medication that liberally because their heart rate becomes very slow and they're not in AFib. So there are some challenges over here. We already talked about stroke prevention, right? So stroke prevention includes oral blood thinner. A lot of people are on oral blood thinner. There are some occluder devices such as Watchman. Actually, there's some brochure about Watchman over there. We do Watchman in this hospital as well. So this is something that we can talk about in probably a later talk. Lifestyle changes a big time. Okay, so a lot of risk factors for AFib. The only one you cannot do is your age, right? So age is a risk factor, but you cannot do anything. But alcohol, sleep apnea, blood pressure control, right? So these are obesity. These are common lifestyle changes. So I don't think these are mutually exclusive. It's not like, oh, you're so obese, you're not eligible for anything. But these are very, very complementary, right? So if I have a patient, they're obese, right? So I would say, yes, we can consider this and this and this treatment, but how about you lose some weight? Okay, how about you cut down your alcohol drinking? These are very important. Sometimes these alone is very effective, sometimes more effective than, like, for example, today's talk, PFA, right? So it's very important for a person to know this comprehensive management. And we can focus on that down the road in a later talk. Today, obviously, our talk is about rhythm control, right? So rhythm control, broadly speaking, is ablation and a drug, heavy-duty medication, ablation and heavy-duty medication. And our talk today is about ablation. Some of you already have an ablation, had an ablation, or had one ablation, or are going to have another ablation, right? Ablation, in my opinion, is not the greatest term for this, procedure, right? So sometimes I joke about my plumber colleague, right? So they come in, patient with chest pain, abnormal stress test, they go in and say, oh, there's a blockage, let's put a stent. Let's open it up, the blood vessel. Your valve is tight. Let's put a new valve. Let's open it up. It's very easy for people to have that concept. Open it up, put a stent, keep it open. These are positive terms, right? Ablation is a negative term. You're somehow ablating, get rid of some tissues. Ablation is what we do, yes, but what we're trying to really do is to do something called isolation. we're trying to electrically isolate the bad cells that generate AFib, right? So it's a negative and turn out to be positive. We get rid of bad things and turn out to be good. A better term would be electrical correction, right? So that's what we do. When we do ablation, it's trying to correct the electrical system of the heart. We remove the bad cells that generate AFib, maintain AFib, let the good cells to take over, right? You have good cells to take over. That's how you were born with. You still have that good cells. But with the bad cells, it's like bad friends. You have to, isolate them, get rid of them, quarantine them, so your good cells can take over. So let's go back to this film, this picture again. In normal rhythm, our good cells coming from our natural pacemaker, right? We call it sinus node. That's why we call it sinus rhythm a normal rhythm. Natural rhythm coming from this sinus node. And it comes down to the bottom. This is a very rhythmic. The top chamber beats, the bottom chamber to follow. Very rhythmic motion. In atrial fibrillation, the top chamber quivers. And the most common sites to generate these bad rhythms, to tickle the heart into AFib, actually come from these blood vessels. And where are these blood vessels connected to? One end is to the heart. The other end is to the lungs. Okay, so these are the blood vessels that connect from the lungs to the heart. Okay, we need that plumbing system. We need the blood. Those blood are full of oxygen, right? You take a deep breath, those oxygen go into your lungs, those blood filled with oxygen go back to your heart and then pump to the rest of your body. We need that plumbing system. What we don't need is this electrical system where this blood vessel, they join the heart. There are specialized cells, and we don't know what they're there for, to be honest with you. There are parts of the organ we really don't know what they're there for, like appendix. Gallbladder still has some function. There may be some function for these cells. These cells, what it can do is it can beat super fast, okay? Most of our heart cannot beat this fast, but at this junction, these cells, they can beat very, very fast. So it can put a person into atrial fibrillation, on a bad day, maybe after a tequila or a bad night or get emotional stress. These cells can get very crazy and put your heart in AFib. And these blood vessels, where they join the heart, is the target for our quote-unquote ablation, or our electrical correction. Okay. So these are just the animation, basically what we do or what we have been doing. Some of you had something called cryoballoon ablation. So basically what we do is we go in with a wire, see this electrical system coming out, we inflate the balloon and it kind of touch around and then just freeze, right? So once you freeze for a few minutes, you leave a circumferential scar tissue, right? So you ablate, quote unquote, these rim of tissue that render the electricity cannot come in. So we isolate, we put a roadblocks, okay? We basically put a roadblocks for these bad electricity that cannot come in, right? So depending on how your roadblocks is doing, sometimes you have gaps and all that kind of thing. So a lot of times we put in these roadblocks kind of in a interlocking way so that there's no gap they can come in. So imagine the bad guy coming from here, these are pulmonary vein, these are the blood vessels, the bad electricity coming through, and this is the part of your heart. You really want to block those signals. The better you block it, the better your results is. So for the past about 15, 20 years, it's on the right side. These are, we call it radio frequency ablation, okay? So these are different energy source to achieve the same results. What we're trying to do is to get rid of the signals coming from these blood vessels, right? So what you're gonna do is to create scars around it so that the blood can flow through, but electricity cannot conduct. So for the past 15, 20 years, that's the only way, by burning inside the heart. We call it radio frequency. and create a circumferential scar. For about 7 years or so, this is a newer technology called cryo balloon. You basically a single shot approach. You inflate the, the balloon and kind of ablate circumferentially. And these are what we had, for many years. And I think they did a decent job. They kind of improve on these catheters, and we kind of know the potential complications, and we kind of monitor, so they can be done very safe and effectively. And we kind of joke about these are fire or ice, right? So in the past, we only have either heat out the tissue or cool down the tissue. These are two energy sources. And they compare to the drugs, they're all better, right? So in terms of efficacy and toxicity, et cetera, they're all better. The problem with these two energy sources is because the thermal energy, what we use, right? So if you heat up a tissue or cool down the tissue, remember what we're trying to ablate or get rid of is the junction of these heart cells. What we really don't want to damage is the neighbors, okay? So a lot of people, even my interventional colleague, they may not know. Actually, this is when I started to my area of subspecialty in cardiology. I started to notice, oh wow, their heart really have neighbors that we don't even pay attention to. One important neighbor on the back of this area is our foot pipe or esophagus, okay? It's connected your mouth to your stomach. That long tube that runs very close to the heart, believe it or not. On the front side, there is something called phrenic nerve, all right? So these are the nerves that control the diaphragm, control your breathing, basically. If you damage these vessels, damage these structures, it can cause problems. If you damage the phrenic nerve, people can have very, very bad short of breath. It can take time to recover, but it's miserable. If you damage the esophagus, is very bad. All right, so their case report incidence is super rare, but theoretically you can create a communication, we call it fistula, between the heart and the esophagus, and the mortality rate is usually 100%, unless you have a surgical repair, and this is a big surgery. So yes, the incidence is much lower now because we are aware of this complication. So when we are around that, we become very, very careful. We don't let the temperature go too high inside the esophagus. We monitor the temperature inside. When we burn, okay, when we freeze, we monitor that. As long as your temperature doesn't fluctuate too high or too low, it is very safe. But still, this risk is always linger, right? So when you do ablation, you always worry about, and you're gonna see some pictures, worry about a lot of things, and these are other two things you have to worry about. Now, this is the reason why I think we've been kind of wanting this technology to come in, all right? So in fact, PFA has been CE marked, available in Europe for more than 2 years before FDA approved in February. So they done like, I think 40,000 cases before the FDA approval. And we are on Twitter, we are on these, convention, national convention, we all hear this German guy or French guy, they're talking about how fast, how safe they can do these technology, and we're like, investigational over here. So we cannot do anything over here. Until February, somewhere in February this year, FDA finally approved this system. So, and we're very excited. So what is PFA? Okay, so this is a slide that is not related to cardiology. As you know, these are juice, right? So PFA basically is to apply high electrical field, very, very high electrical field, high intensity electrical field. In food industry, so let's say if you have some juice, you apply the right electrical pulses, you can destroy the harmful bacteria without affecting the nutrients, okay? And this is the key. You can selectively destroy the things you don't want while preserving the things you want, okay? So in milk, in juice, they use this to enhance your shelf life because you kill the bacteria. You don't want to burn it, you don't want to cool it because you can affect the nutrients. So this is kind of the, the idea they borrow from maybe food industry. They are probably decades ahead of medical use. And in medical use, our field is not the first one to use it, right? So PFA was long before this. They are available in oncology. When they ablate the cancer cells and tumor, they use this as well. What it does is to apply high electrical pulses. The cell membrane will open, okay? It is like this whole room over here. If you apply a very high intensity electrical field, this wall will start to have a lot of pore forming. And then what is inside is going to leak out. This cell is going to die. Okay, so that's the end result. And this is what we want. We still want to kill cells. We still want to ablate cells. So we want a irreversible cell death. But this is the mechanism. Instead of cooking the cells or freezing the cells, what we're trying to do is to let a cell open up their pores, form a lot of pores over their membrane, and the cell is going to lyse and die. So what is PFA? This is one of the animation of the catheter. Basically, we're doing the same thing. Remember, we put a wire in and we inflate the balloon. It's the same thing. We put a wire in and then just use this catheter and then apply energy. We're doing the same thing with a different energy source. So I think you asked me about, is there a specific training for this? I think the learning curve is probably just do 1 or 2 vein and it will be like a pro, right? Because as you mentioned, it's like a screwdriver, a Phillips screwdriver or a regular screwdriver. Sometimes I talk to the patient, I said, if you want to get a nail to a wall, you can use a fist, you can punch it in, or you can use a spoon, or you can use a hammer, right? So it's a different tool for different the same results. And I think this is a more efficient way and safer way. And this is a very complicated slides, but this is very difficult. I think a lot of variables are into the engineering, and they when they started the preclinical studies, they have to develop a kind of a template, and when they start a clinical trial, they have to refine this. But now I think we kind of figured it out. We use this very standard, we call it optimal waveform. The beauty of PFA, okay, while we're talking about all these, is this slide, okay? So the beauty of PFA is if you do it right, okay, how do you do it right? You have to kind of trial and error. From before that slides, you have to determine how much impulse you're going to give in a given drivetrain, what is the intensity, how much longer each pulse width is. If you do it right, you can selectively target the cells you want to target without affecting other tissues, right? So it's very specific to certain cells or tissues. For example, myocardium has a specific number, whereas nerve have a different number, right? So remember we have phrenic nerve, we have foot pipe. Foot pipe is the vascular smooth muscle. They have a very different threshold to affect them, right? So when you apply the optimal waveform, you're not going to affect them. You don't even have to monitor them. The incidence of damage to that structures outside of the heart is very, very minimal, if any. So that's the beauty of this. So remember this slides. When you do heating, when you do freezing, you kind of worry about the damage. You have to monitor. You have to put a temperature probe inside the fluid pipe. You have to stimulate. Actually, we have to stimulate during the procedure. You have to make sure your phrenic is capturing every second. If it doesn't capture, you have to stop immediately. And that's always, it's not like too long, but it's a 4 minutes freeze, and it kind of feels forever. When you do pulse field ablation, you don't have to do it anymore, right? You're not going to affect them. So you do this, you don't have to monitor. The incidence is 0. They did hundreds of studies. That take away a lot of worry, complications, anxiety among the operators, I would say. What are the studies show? Okay, so this is a landmark trial for the very system we have here. they published, I think it's several months ago. They compare the PFA system with the thermal ablation, including the heating one and the freezing one we have. The bottom line in this landmark trial is they're similar, okay? So if you think these are when they just roll out, right? So this is the very first, the operators, they're very experienced in the thermal, the old way of doing ablation, and they are very naive in this new way, right? So one is very new, you never really, done it before, and one is you've done it for years and years. The results are comparable. Some people view it as somewhat a negative trial, but I think it's pretty good, for comparing this. And I would say for myself, the learning curve is very, very fast. After the first couple of applications, I feel like I've done this before. And what it doesn't show here is the efficiency, right? So I don't feel like I'm rushing, but I can finish the case maybe 30% faster. And I don't have to worry about that process of potentially damaging the collateral organs, right? So this is a very, very rewarding experience for most of us. Finally, I'm going to talk about how this is done since we launched this PFA over here. So I think, I'm the one who's talking today, but, there are a group of people inside that cath lab or operating room. So obviously a cardiologist who's leading the procedure. There is a right-hand person, usually a scrub tech or a radiology technologist who's helping out flushing the sheath, keeping the wire, make sure things are, not falling down the tape on the ground, and make sure you operate the X-ray and help you. And we have two nurses. One is circulatory nurses. So when we do this procedure, we want to make sure the patient's blood is thin, right? So you're on a blood thinner, we hold it. Usually some doctors, they don't hold, but most doctors, they hold one day, maybe 24 hours. During the procedure, we don't want any clot. So standard procedure, we give IV something called heparin. We want to make sure your blood is in a certain level. And then, so we have a dedicated nurse to just make sure, your blood is in a certain level. That's very important. And we have a recorder nurse who is basically doing this pacing and monitor the electrocardiograms. And we have industry support from this company who manufactured this PFA. They're very helpful, kind of help us along the way. And we have something called 3D mapper. All right, so when we do the procedure, we rely on a lot of inputs. One of them is something we call it 3D mapping. It's like a GPS inside the heart, kind of navigate, help us, which can help our safety and reduce our X-ray exposure for the patients and the operators. And obviously, we have anesthesia staff, right? So this is done under general anesthesia at this moment. So people won't feel anything, don't remember anything. So starting the case, the scrum tag is going to flush every sheath, and we're going to make sure everything is properly tested before we insert it into the human body, right? So all these are manufactured out of the box. Before we go in, we need to make sure there's no defect. Everything is just as properly expended. And there are samples of these catheter over there. If you want to feel it, you can feel it. It looks much bigger on the X-ray screen, but actually very small. And this is already a kind of a large footprint already. So this is a slide I show. This is the actual patient with his permission. Our entry site is through the right groin, okay? Our right groin has a big vein. They go up to the heart, superhighway to the heart. And that's how we inserted this IV sheath that allow these catheters to go to the heart. 95%, I spare the left groin. One is for the post-op comfort. Sometimes people can kind of bend their left knee if they're back issue, but if you enter the left groin, you cannot do that. And for the recovery as well. If you have two groins, you have to worry about both sides, but one groin, you only worry about one side. For the most part, this is kind of how we do ablation. I bring the chair to sit down and relax, and then and I watch these screens. This is a kind of a demonstration. Actually, this is very easy to understand. You have an electrocardiogram over here. See this 5 pulses here? These are the electro pulses that deliver through the catheter to the tissue that we're going to ablate. And as you can see, these spikes are, let's call it bad signals. Okay, the bad signals that coming from this blood vessel that generates it. After these several spikes, these bad signals are gone, while these good signals are still here, right? So the bad signals are gone, and we make sure we do proper, basically according to the the guidelines, several applications to make sure it is durable. A lot of times your first application is gone, but we make sure we have some overlapping lesions, and then make sure this is durable. And during the ablations, as I said, we need to monitor a lot of things. All right, we still have to monitor a lot of things, although we don't have to monitor the temperature of the throat pipe and the breathing nerve activity. But we still have to monitor the blood pressure and the heart rate continuously. This is very important. We monitor the X-ray. There's a screen over here showing the X-ray. We have something called intracardiac echo, right? So we insert it through the groin, not only the ablation catheter, but also a catheter that can see, it's like a sonogram inside the heart. And it's displayed the screen over here. And then we also have this 3D mapping over here and the electrocardiograms. So there are several inputs that continuously feed in. And when you do the ablation, you kind of have to see it comprehensively. So I think these multi-modality monitoring make it very safe for the procedure. If there's anything wrong, immediately we'll notice. Okay. So far, this technology was launched about 2 months ago now, roughly 2 months ago now. And this is my own data, but between, we have 3 doctors. You can triple this number. So far, my experience has been great. All the patients, they go home the same day. Really, I don't recall any issues. As I said, I'm a big cryo balloon user before this technology. And since we started this, I haven't done a cryo balloon case over here. What I noticed is sometimes when people have after the thermal ablation, after we're done with the case, before they go home, they have this kind of weird chest pain when they take a deep breath in. Not all of them, but some of them. And sometimes we have to give them a shot of anti-inflammatory medication. That's very common. Sometimes the nurse doesn't even ask me. They know that's my protocol. Give them some pain shot. After this, I've never get called for this. Right. So this is something that I think I don't know how to say that. If you touch something very cold or very hot, even after the fact, you have this burning sensation. Kind of lingers. This one, like you go to an electro field and come out, you probably don't feel anything, right? So really a selectivity is really the key here. So after the ablation, what we do is we see patients at CBN office. We call it AFib school. So we see them back in 6 to 8 weeks, usually trying to make it give or take, make sure the groin is okay, do an EKG, make sure they're still in more rhythm. Then we see them back in 6 months, do a monitor, and then 12 months. So in 12 months, if they're doing okay, in general, you don't necessarily have to see us every so often, but you can see us back in every year. Yes, if you go back to that original seminal paper that got FDA approval, the success rate is in the range of 77% or so. Okay, so this is not 100%. Nothing is 100%. But I think that's why I think a lot of time is to pick the right patient to do it. There are patients who in AFib for 10 years, they want to do the ablation, they want to get rid of it. yes, we can do an ablation. I can do an ablation on a patient without AFib, right? But you want to have a right expectation. There are people you can do one ablation and kind of really help them really well, fix them, they feel better. There are patients who probably not a good candidate for ablation. And what we can do for those people, that's for another talk, right? We still can do a lot of things for those people. All right, so these are the facility. This is the very institution you're sitting at, UnityPoint, Trinity, and Rock Island Heart Center. So far, this is the only place in the Quad City that offer this technology. Right now, I think between me and other two electrophysiologists over here, I think this is overtaking all the other energy sources, has become a mainstream of doing this. And this is kind of a similar trend elsewhere as well. I think when the doctors started to feel something that is appear to be safer, I think safe is very important. You know, when you do this, these are elective procedure, right? People don't need to have this. Seriously, yeah, people don't need to have an AFib ablation. And that's why a lot of old school cardiologists, they're like, why do you need this? You know, you don't need to have this. You can live in AFib for the rest of your life. It is because it is elective procedure, you want to value that safety even higher, right? If you go to a hospital for a acute heart attack, that safety becomes less relevant because if you don't do it, patient's gonna die. But this one, safety is very important. So I think in order to achieve that, you know, yes, it's not 100% safe, but it's safer. So if you have a better tool, I think this is the way to go. And we all have office in CVN, Moline, you know, Davenport, and Edinburgh, some outreaches. We can see you after or during the consultation. So this is my last slide. So if you have any questions, I'm happy to. Yes.
Has there been any studies to compare the success rate, like after a 2-year period of people staying in rhythm after this procedure versus fire and ice?
Yeah. So the question is the success rate after 2 years. Okay. So the data I presented was 1 year. That's a standard. So most clinical studies for AFib evaluating the efficacy is a 1 year success rate. Okay. And this is something that, first of all, I need to know how long I have here before the people kick me out at 6:10. So we need to know the quote unquote success rate. Okay. The success rate of a clinical study, and that's what the number of 70% sometimes stick into people's mind. People said, why do you do something that success rate is only 70%? You need to know that 70% means if you have a 30-second in a year of time, if you have 30-second of recurrence of atrial, not just atrial fibrillation, but also something called atrial tachycardia, not a normal rhythm, 30 seconds, all you need. And after 3 months, okay, so there is a term called blanking period. Okay, what it means is right after the ablation, it's like you clean up a very dirty room, right? In the first 3 months, we let the dust settle. People can go into AFib in the first 3 months. That generally does not 100% translate into a procedural failure, right? So first 3 months, after first 3 months until 12 months, that's what most clinical studies, 3 months to 12 months. If at any point you have a 30-second, whether you feel it or not, they do monitor and report as well. 30 seconds of atrial fibrillation or atrial tachycardia, it counts as a failure. Okay, so I'll give you a very extreme scenario. I have AFib. I have hours of AFib 2 times a week. I feel very debilitated. Then I have ablation. 9 months after my ablation, I have a 3-minute episode of AFib that, you know, maybe I feel some, but it terminated. In this clinical trial, I'm a failure. I'm a failed ablation, you know. But to me, this is an absolute success. After a knee replacement, can you run without pain? Maybe, you know, no. But your tolerance of the usual dose painkiller becomes, you know, I think that the clinical trial, they use a very strict standard so that you can compare. Yes, we have patients, their AFib seems to be cured. You know, there's no evidence of recurrence of AFib. But what we see more and more is the AFib burden goes down significantly. And that's the very reason that there are people who want to ask, can I stop my Eliquis or Xarelto or warfarin, right? That is a harder question to answer because you can hypothetically feel great, but you may still have AFib that you just don't know. And if your risk of stroke is really high, stopping the anticoagulation or blood thinner without a proper protection is risky. So at the end of the day, these ablation is to make people feel better, right? So improve their life quality, maybe reduce some risk of stroke, maybe reduce risk of heart failure. But I think that is why if somebody who truly don't feel their AFib, truly don't, and their heart rate is controlled, the bar of offering ablation is higher. It's not like you can't do it. You know, people can still do it if they're, you know, they don't like the idea of being AFib, or their heart is kind of weak. There are criteria for those people, but the people who benefit these type of ablation, PFA, or you know, are the people who really feel their AFib. They feel bad, right? So those, the worse they feel, the benefit, the higher benefit they're gonna have. Yeah.
Thank you.
Yeah. Okay, go ahead.
About insurance, is this difficult to get
Yeah.
covered? And I mean, would insurance be more willing to pay for the one of the older procedures as opposed to?
Yeah, so a very good question. I think the insurance, when we deal with insurance, they approve for AFib ablation as a disease, something called DRG. It's basically a code. They pay the same fee for whatever method you use. Well, I haven't encountered any insurance issue so far with this. These are not like a newer thing, really. So, yeah. Teresa, do you want to be a counter? Who would raise their hand first? I feel like I'm gonna irritate some people if I pick wrong person. Yeah. Who was the question? Okay, that one first. Sorry, I'll get back to you. Yeah.
On your AFib school,
Yes.
for the 6-month and 12-month checkup you had, there was a, I don't know, each line, 1 week ambulatory monitor. Is
Yes.
that an older monitor or is it some other?
Yeah. Yeah. That's basically a long-term holder, or some people call it endcott. Basically is, you know, it's offered by our office over there. It's like a stick on your chest, and you can shower, sleep with it, and you know, after you're done, you can return it. Standard procedure, yeah. You want, yeah.
Yeah,
Can you go off of, can you go off of your AFib drugs?
Yeah. AFib, okay, so I'll get back to you. So AFib drug is, yeah, it's not my talk today, but there are, broadly speaking, there are 6 drugs we use very more often. 3 categories. I briefly divided them into the drug that require a normal heart, the drug you have to start in the hospital, and the drug that you can use in everybody, but carries a laundry list of toxicity. So, you know, there are limitations for each drug as well. Yeah.
But I mean, if you have this procedure, do you have to continue with those drugs?
Yes, okay, very good question. So if I have a patient never been on a drug, okay, never been on a drug, and now the medical society guideline actually gives us a class 1 indication, which is you can do it because there are 3 back-to-back trial in 2021 that show that the AFib ablation, and all of them are cryoballoon, right? So at that time, there was no PFA. There was no PFA. If somebody has symptomatic AFib episodes, you don't need to try drug anymore. You can go ahead and schedule the ablation because they do better. Now, if somebody who is already on a drug, and typically are those people who are stuck in AFib, you have to shock them, right? So when I see AFib, nobody's AFib is the same. Nobody. Everybody's AFib is different. But broadly, you can divide them into two groups. Number one is their AFib comes and goes. You don't need a shock to get out, for example. Those people, they respond to ablation very well, very well. The one who needs to be shocked or cardioverted, those people in general, I like to put them on the medication, one of those 6 medications, and shock them, keep them in normal rhythm, they feel better. Then I discuss about ablation. Now, after the ablation, I don't like to leave them on drug for too long. Because now you have an ablation, you want to test it out. So when I see them back, I will, obviously, I'm going to make sure they're doing well, they're in normal rhythm, right? And if they are, and they are motivated to stop the medication, which I think is reasonable, and I will stop the medication. So unless the patient, there are some medication they're quote unquote benigner than others. If a person who is like, absolutely, I don't want to go back to AFib, I don't mind taking this medication, that's okay, case by case. Yeah. Okay, go ahead.
So I hear so much about robotics.
Yeah.
Is any part of this robotic surgery or is it?
Robotic surgery has been used in a lot of other medical field. Actually, believe it or not, in EP, in our electrophysiology, there is a similar, not exactly the same, but similar platform where you can operate in front of a computer and the magnetic field can operate the catheter for you. It's falling out of favor. It's very expensive to introduce and to get rid of. I think so far this one is all person operated. And I think I've seen people do that quote unquote robotic for ablation, but I think it takes longer and then it's just not doesn't sometimes you click so many buttons, all you need to do is go up and just rotate it. Yeah, so it's not like a really rewarding process. I think that's the reason why they falls out of favor. Yeah, go ahead.
You mentioned there's 3 doctors that do the ablation.
Yeah.
Area.
Yes.
What's the lead time on the EFA right now? You would say your candidate would do it.
Right. I can speak for myself only. I think other 2 doctors are probably similar. I think usually when you see a consultation, you sign up for this case, the typical wait time is about 6 weeks or so. 6 weeks or so. Yeah.
Somebody's telling me the other day in Iowa City that's also had.
Yes. Yeah. Yes. Iowa City, they have it. Actually, Cedar Rapids, they had it more recently. I'm sure Peoria, Chicago. Yeah, this is very widespread now. Yeah. Yes, go ahead.
If your cryoablation fails,
Yeah.
are you still a candidate for PFA?
Very good question. So I have done a PFA, maybe 2 of them. They're previously failed ablation. They're all radio frequency. The utility of PFA, I don't know if you remember, but I put something called postural ablation over here. So this is really not my realm of talk, but I think because of this is safer, there are a lot of things we used to do with caution, extreme caution, but now with this, we don't have to worry anymore because it's not going to affect the backside of the heart where the foot pipe is. So if I have a candidate who failed or who had an ablation before and now they want another ablation, I think PFA is a great tool because all you need to do is to, go back in and, just use this. And yeah, a lot of areas where previously they probably didn't do a very thorough ablation for the fear of affecting other organs, you don't have to worry about that anymore. Yeah.
Now it's time to pick a number, Dr. Shen. You need to
Oh,
do-
pick a number. Okay, sure.
Yeah, very importantly, we have the basket here and we turn around.
Wow.
Okay, we got lots of goodies in there. So go ahead, pick a number.
Everybody's question is answered? Maybe?
So what's the first step? Calling for a consultation? Calling to make an appointment?
Yeah. Okay, yeah.
You need referral?
Ideally, but yeah, self-reference.
Okay, so the lucky number is 64085. Oh, there we go. We got somebody. Awesome. So we got a winner here. So, and I want to just double back, Dr. Shen, thank you
Thank you.
for the presentation where you really broke down this cutting edge treatment option PFA into really understandable steps for us that don't have a medical background. So I really appreciate that. Thank you.
Yeah.